Welcome to this explainer. Today, we are taking a deep dive into human fetal development. But listen, we aren't just going to look at this as some simple, boring timeline you have to memorize. No way! We're going to treat this as what it truly is, an absolute masterclass in biological survival and adaptation. I mean, think about it. We are talking about the frankly mind-blowing journey of a microscopic, single cell transforming into a fully viable human being. A human that is completely equipped with its own temporary, highly specialized life support systems. It's just an amazing biological arc. And by the end of our time together today, you are going to have a rock-solid, practical grasp of the clinical realities of how human life adapts to survive before birth. This is going to be especially perfect if you're gearing up for the NCLEX. Let's get right into it.
Okay, let's dive into our structural roadmap for today. First up, we'll cover conception and the genetic basics. Then, we'll move into those incredible life support systems I mentioned. Third, we'll hit the major fetal development milestones. Fourth, we'll tackle fetal circulation and shunts, which is a huge one for exams, by the way. Fifth, we'll look at the unique science of twins. And finally, number 6, we're going to wrap it all up with an NCLEX-ready knowledge check to make sure all this high-yield info really sticks.
All right, Section 1, Conception and Genetic Basics.
So every single human adaptation begins right down at the microscopic level. Long before any organs or complex life support systems can form, the entire foundation is laid at the genetic level. It starts with exactly 46 chromosomes containing the intricate DNA code that dictates all of human growth. And notice where the magic actually happens here. Fertilization normally occurs in the outer third of the fallopian tube, right up near the ovary. It's pretty incredible. As soon as a single sperm penetrates the ovum, boom, a chemical change instantly happens in the membrane that completely prevents any other sperm from entering. It basically locks the door. From there, the newly formed zygote starts undergoing rapid mitotic division, which we call cleavage. It travels down the fallopian tube over a matter of days, multiplying into a solid ball of cells called a morula, and then eventually becomes a blastocyst, right before it finally burrows into the richly prepared lining of the uterus for implantation.
Now here is a crucial time frame you need to commit to memory. 5 days. This is a massive, high-yield clinical alert, especially when we talk about family planning counseling. You see, while an ovum, the egg, is estimated to survive only up to about 24 hours after ovulation, sperm are a whole different story. Sperm can actually remain fully capable of fertilizing that ovum for up to 5 days after being ejaculated into the cervix. Understanding this biological window is absolutely fundamental for reproductive decision-making. Why? Because pregnancy can absolutely result from intercourse that takes place up to 5 full days before ovulation even happens. It's a game changer when you're counseling patients on fertility.
Moving right along to Section 2, the life support systems. Okay, now that we have a developing zygote implanting in the uterus, we really need to shift our focus to the accessory structures of pregnancy. These are temporary, highly specialized life support systems that step in to make fetal survival and growth entirely possible. When you look at the relationship between the maternal blood in the intervillous space and the fetal chorionic villi, there is a massive takeaway you cannot forget. Maternal and fetal blood supplies do not normally mix. Let me say that again. They do not mix. Instead, oxygenated, nutrient-rich maternal blood spurts into these spaces, and then the fetal villi absorb those nutrients and release waste products right back across a super-thin placental membrane. Think of it like a high-tech biological filtering system. It's elegant, it's highly efficient, and it protects the vulnerable fetus from potential pathogens or incompatible blood types, all while delivering exactly what it needs to thrive.
But here's the thing. The placenta isn't just a physical exchange barrier. It's actually a wildly active endocrine gland that churns out 4 vital hormones for survival. Let's break these down because they are super important. First up, progesterone. This is the stabilizer. It maintains the uterine lining for implantation and crucially reduces uterine contractions to prevent spontaneous abortion. Second, we have estrogen. This stimulates uterine growth and ramps up blood flow to the reproductive organs. Third is human chorionic gonadotrophin, or HCG. This is the biological signal that sustains the pregnancy early on. It basically yells at the corpus luteum to keep producing estrogen and progesterone until the placenta can take over. Clinically speaking, HCG is the exact hormone we are looking for in standard pregnancy tests. And finally, human placental lactogen, HPL. This one is fascinating. It causes decreased insulin sensitivity in the mother. Now you might be wondering, why on earth would the body do that? Well, it's an incredibly clever adaptation, ensuring that more glucose remains floating around in the maternal bloodstream, making it readily available to meet the intense, growing energy needs of the fetus.
Connecting the fetus to this amazing placenta is, of course, the umbilical cord.
The literal lifeline. Let's highlight a massive, non-negotiable rule for your nursing exams regarding the structure of the cord. Just remember the mnemonic AVA, artery, vein, artery. The cord normally contains two arteries that carry deoxygenated blood and waste away from the fetus, and one single vein that returns oxygenated, nutrient-rich blood to the fetus. I know, it's the exact opposite of how adult circulation works, which is why they love to test you on it. Now, protecting these crucial vessels is a specialized substance called Wharton jelly. It's a firm, cushion-like material, kind of like biological bubble wrap, that covers the vessels and keeps them safely separated. This allows the cord to move, twist, and stretch as the baby flips around, all without restricting circulation. Because without Wharton jelly, a simple twist or compression of that cord could literally be fatal.
All right, Section 3, Fetal Development Milestones.
Let's transition over into the actual physical growth of the fetus. We are going to look at just a few of the most critical developmental milestones, specifically the ones that map directly to a fetus's clinical viability. Honestly, the development happens stunningly fast. By just week 3, a primitive tubular heart is already formed and physically begins to pump. By week 8, which marks the end of the embryonic stage, the beginnings of literally all bodily systems have developed. Ovaries or testes are present, and purposeful movement actually begins, but I want you to heavily highlight week 20 in your notes. This is known clinically as the age of viability. At exactly 20 weeks, the lungs have matured just enough functionally for the fetus to potentially survive outside the uterus. However, and this is a big however, because the respiratory and neurological systems are still profoundly immature at this stage, survival strictly requires highly specialized, round-the-clock neonatal intensive care.
And as we push forward to week 25, the physical adaptations become really remarkable. The fetus is now covered in fine hair called lanugo, and there's this cheese-like substance called vernix caseosa that coats the skin to protect it from becoming totally macerated by the amniotic fluid. But the real headline for week 25? The lungs begin to secrete surfactant. Listen, this is a massive, game-changing leap in clinical adaptation. Surfactant is this crucial lipid substance that keeps the tiny air sacs in the lungs, the alveoli, from collapsing completely flat during exhalation. Imagine trying to blow apart 2 pieces of wet tissue paper. Without surfactant, that's what the baby's lungs are like. With surfactant, extrauterine survival becomes significantly more likely. That brings us to Section 4, Fetal Circulation and Shunts.
Okay, grab some coffee because we have arrived at perhaps the most complex and heavily tested system we will cover today, fetal circulation. This is essentially the story of how the fetus gets oxygen without actually breathing air. It's a circulatory system built entirely on physiological diversions. Think about it. The fetus is completely submerged in amniotic fluid, so it obviously doesn't breathe air. Furthermore, its liver doesn't need to process most waste products because the mother's body is handling all of that heavy lifting across the placenta. Therefore, routing massive amounts of blood to the fetal lungs and liver is just a huge waste of cardiac energy. So, to solve this clinical puzzle, the fetal body utilizes 3 temporary shunts to effectively bypass those organs altogether.
Let's systematically break down exactly how all 3 of these essential shunts work. First, we have the ductus venosus. This structure diverts some of the blood away from the liver as it returns from the placenta, routing it straight toward the inferior vena cava and up to the heart. Second, the foramen ovale. This is a little flap that diverts most of the blood from the right atrium directly across into the left atrium, completely bypassing the non-functioning lungs. Third, the ductus arteriosus. This one diverts most of the remaining blood from the pulmonary artery directly into the descending aorta. Now, the absolute clinical magic happens the moment of birth. When the infant takes its very first breath and cries, blood oxygen levels spike, the lungs rapidly expand with air, and vascular resistance in the pulmonary system suddenly drops. This dramatic, sudden shift in pressure causes all 3 of these amazing shunts to snap functionally closed, completely transitioning the baby over to independent newborn circulation. It's incredibly cool how it all just works instantly.
Moving into Section 5, the science of twins.
Let's pivot now to another fascinating variation in human development, multi-fatal pregnancy. This comes with its own completely unique anatomical adaptations as well as specific clinical realities that healthcare providers need to monitor very closely. The core physical difference actually starts right at the exact moment of conception. In identical twin development, embryonic tissue from one single fertilized egg splits into 2 completely distinct embryos. But in fraternal twin development, 2 entirely separate ova are released by the mother, and they happen to be fertilized at the exact same time by 2 completely different sperm. The crucial point for you to understand here is the clinical implications of these two distinct types. Monozygotic or identical twins are genetically identical, they are always the same sex, and here's the big kicker, they often share a single placenta. This can lead to some really complex clinical complications with unequal blood supply variations between the two fetuses. Now, on the flip side, dizygotic or fraternal twins are basically just siblings who happen to be sharing a womb for 9 months. They have two of literally everything. 2 amnions, 2 chorions, and 2 totally independent placentas. Interestingly enough, dizygotic twin incidence actually increases naturally as maternal age goes up. But regardless of which type it is, all multifetal pregnancies carry a significantly higher risk of premature birth. Why? Well, it's pretty simple physics. The uterus can only stretch so much. It eventually becomes overly distended by the sheer volume inside, and that extreme stretching acts as a mechanical trigger to kickstart early labor.
All right, we made it to Section 6, NCLEX ready, knowledge check. Let's see what you remember.
Okay, it is time to put everything we've just discussed into practice. Let's test your retention of this explainer with 3 hallmark questions derived directly from the source material. These are designed perfectly to mimic NCLEX-style testing, so let's see how you do. Here's your first question, and everybody loves a classic select all that apply. Which facts are true regarding the structure of the umbilical cord? Does it contain 2 veins and 1 artery? 2 arteries and 1 vein? 2 arteries and 2 veins? Does an artery carry blood away from the fetus? Does a vein carry blood to the fetus? Take a brief second, think back to our life support section, and lock in your answers.
All right, let's break down the rationale. The correct answers are, it contains 2 arteries and 1 vein, the artery carries blood away from the fetus, and the vein carries blood to the fetus. Remember that absolutely crucial AVA mnemonic we established earlier? Artery, vein, artery. If you just remember AVA, it's the simplest way to ensure you never get this high-yield anatomy question wrong on exam day.
Moving right along to our second hallmark question, why are twins often born early? Is it because the placenta becomes distended? Is it because the maternal body cannot tolerate the weight? Because the fetuses become too large to deliver vaginally? Or is there another primary physiological reason we discussed just a few minutes ago? And the correct answer is the uterus becomes overly distended. Linking this right back to the physical realities of the anatomical adaptations we covered in the twins section, the sheer physical volume of multiple fetuses, 2 placentas, and all that extra amniotic fluid stretches the uterine muscle significantly. It's like blowing a balloon up just a bit too far. This overdistension acts as a direct mechanical trigger that tells the body, okay, time to go, initiating the labor process premature. And for our final, highly specific anatomical question regarding those temporary diversions of fetal circulation, which fetal circulatory shunt diverts most blood from the right atrium directly to the left atrium, completely bypassing the lungs? Think back to the 3 shunts we meticulously mapped out earlier. Which one goes atrium to atrium? The correct answer is the foramen ovale. If you nailed that one, you are doing incredibly well. As we wrap up today, I want to leave you with a rather provocative final thought. We've talked extensively about anatomical growth, right? But the source material also highlights a fascinating concept called fetal programming. Research actually shows that things like intrauterine undernutrition can result in permanent, lifelong changes in fetal structure and metabolism. This can actually influence the development of serious conditions like heart disease and stroke decades later in our adult lives. It just proves that fetal development isn't merely about preparing a baby for birth. It's literally programming the blueprint for our entire adult health span. It really makes you realize how unimaginably vital maternal-fetal health truly is. Hopefully this leaves you eager to explore this amazing subject even further. Thanks so much for joining me today, and keep learning.